available off the shelf, and CAR T cell slot may take some time. And similarly, the patients who have comorbidities where they cannot tolerate the side effects in the form of CRS or ICANS, the BiTEs may be like more preferable options because the intensity of or the severity of CRS and ICANS is less as compared to the CAR T cell therapy. So my question to Dr. Hari is, among the approved products, teclistamab versus talquetamab combination, and what are your views on a BALL like paradigm, BiTE plus monoclonal antibody in future?
So that again is the trial which is ongoing, which is combining a BiTE with a monoclonal antibody. They have combined daratumumab with teclistamab, and I mean there is a rationale behind it because both are two different targets that are using. So we would think that there was going to be additive effect or synergistic effect to that. And the recent ASCO publication also showed a benefit of synergistic value for the combination. So there is a meaning in doing that kind of a strategy because you're using a different targets. But again, it depends upon what has been used, because most of the patients who have reached at this point of time would have already received daratumumab-based regimen in the past. That's the thing. So what next? So we have CAR T cell trials where the CAR T cell therapies are going to be used in high-risk, newly diagnosed myeloma, and it will be exciting to look at the results of these studies. And we have small molecules, the iberdomide and the congeners, which have been like recently come into clinical practice. So I would conclude that there are more treatment options for relapsed myeloma now than ever, and the general principle: do not save for the last for the best, and we should use the best options early on, and triplet should be preferred, and select the best combination based on the patient, disease and treatment characteristics, and there is no perfect sequence.
Thank you, Dr. Aditya, and the panelists, Dr. Chandramouli, Dr. Hari, for this excellent panel discussion. I actually just wish that nobody discuss about the mezigdomide, which is just published last week in New England Journal of Medicine. So anyway, there are so many new options which are coming up. But one thing is there: once the disease relapse, then the prognosis obviously is poor, and you try to do different kind of permutation and combination and try to salvage the patient. But obviously, once the disease is refractory, then it is very difficult to salvage with the available therapy. And that's what was discussed by Dr. Suparno, who I think left the hall. But somebody who is a very high risk, you can consider doing an allo, which is only possible in a developing country, where allo would still be cheaper than giving the very high costly form of therapies. So with that, I think we wrap up this sessions, and thank you to all the organizers, including me, for giving this opportunity. Thank you.
Section, I would like to invite our chairperson on the stage, Dr. Manju Sanger, who is working in Department of Hematology Oncology at Tata Memorial Center, Mumbai. Her area of interest is expert in treating breast cancer, colon cancer, blood-related disorders such as leukemia and anemia. And I would like to invite our second chairperson, Dr. Gaurav Prakash, MD Internal Medicine from PGI Chandigarh, DM Medical Oncology from AIIMS New Delhi, currently working in the Department of Clinical Hematology Medical Oncology, PGI Chandigarh. In this session, we have 3 talks. First talk is being sponsored by Takeda, and third talk being sponsored by ROC.
So we'll begin the session because we are already late. So the first talk is going to be by Dr. Riaz Ahmed, Defining Treatment Landscape in Hodgkin's Lymphoma. Dr. Riaz Ahmed.
Hi, good evening, everyone. So, as already told, this talk is sponsored by Takeda, and the topic given by the organizers is defining treatment landscape in Hodgkin's lymphoma. So, I have only one disclaimer. This is sponsored by Takeda, so most of the slides I have taken is the company sponsored, though few of the slides are my own. Now, evaluation of classical Hodgkin's lymphoma. We know that this Hodgkin's lymphoma, over a period of time, from single agent to multi-agents and intensifying, reducing treatment, PET-based therapy, we have seen it all. So what we were treating 15, 20 years back from ABVD versus MOP, then coming to escalated BCOP, then finally coming to 8 versus 6 cycles of escalated BCOP. Then PET-based regimen came, then we started de-escalating or escalation based on the PET2, whether it is a Rathel study, ABVD followed by AVD when it is good response, or going to the BCOP if it is not that great response. And the things have been pretty the same. And this is what we are still practicing the same in majority of the cases. Things were going well, but the problem started when we have got the targeted agents, nivolumab, brentuximab, and latest kid on the block is pembrolizumab. So where to place these in upfront, in relapse setting, and in post-transplant will be the key. So my talk is basically here in 3 settings: frontline, relapsed refractory patients, and post-transplant consolidation. So coming to the first line patients, so we have been doing, I will not say all the crowd what is present, they know how to diagnose, how to stage it, and which therapy most of in the first line when it relapses the refractory. So we'll go one by one. So this was apart from those Rathel study and the escalated BCOP, we have this when it started brentuximab vedotin with single agent initially, then with chemotherapy for stage 3, stage 4 Hodgkin's lymphoma. Initially, this was the first published in 17. This was the Echelon 1 study. We combined BV with AVD, comparing 1:1 with ABVD. And this we have seen, a lot of presentations have been made, a lot of claims has been made, and of late, this is 6-year follow-up of this analysis showed that significant PFS benefit and also revealed the statistical and clinically important OS benefit in favor of BV-AVD. So estimated 6-year progression-free survival in BV-AVD was 82.3 versus 74.5 in ABVD. In overall survival also, it was favoring brentuximab arm with 93.9% versus 89.4%. So the way it is being, you see a clear trend, but it's not that most of our patients, what we treat, that ABVD is bad. In comparison to brentuximab, okay, brentuximab scores, but ABVD is still holding 80% is not that bad in majority of the patient. But if someone is, I think so in the economics when we say, yeah, if they are able to afford, brentuximab can be considered. This is also again 5-year PFS by PET2 status, and modified PFS was constantly in favor of BV-AVD. These are all statistical comparison when they have done AVD PET2 versus ABVD PET2, or this is overall survival and the PFS estimated. Not only this, they also were able to tell that the need of subsequent relapses, the need of subsequent anti-cancer therapies were less in brentuximab arm as compared to the ABVD arm. And at the 6-year period, there were fewer second malignancies with no substantial differences in pregnancies were reported in brentuximab AVD versus ABD. So this was a concern with ABVD. The pregnancies has been concerned, the secondary malignancies has been concerned. So no, not much difference. Both have been head-to-head, same-to-same comparison. The only thing which mattered in brentuximab arm was 2 complications we see. One is peripheral neuropathy, and the second is neutropenia, which can be easily managed. So the 2-year analysis of the majority of the peripheral neuropathy events were low grade with more than grade 3 events in 11% of the patient in AVD arm and 2% in the AVD arm. This was one of the concern which was raised. And in summary, apart from these two neutropenia, this echelon study said, okay, BV-AVD had a good response and the overall advantage with BV-AVD arm versus ABVD with 41% decrease in death, risk of death and manageable safety side. And NCCN guideline also had this brentuximab coming in the stage 3, stage 4 in the first arm when the patient more than 60 years. Now, this was all with brentuximab. So what other drugs were doing? Like we have this checkpoint inhibitors, this, PD-1 inhibitor, this nivolumab. So initially they had this monotherapy doses, and then again when it was combined with the sequential 6 cycles, and when you can see this in advanced stage disease, stage 2BX or stage 3 or stage 4, see the overall response rate was in the range of 90%, 80 to 90%, and the CR rate going up to 67%. And the 2 years follow-up, it has been remained 84 versus 80%. So this is another one when you combine upfront nivolumab. This is in the checkmate. This also showed the better study. Same with Nivachil. When you have this, they have this 2 arms, whether it is combined, concomitant versus sequential. And when you are giving Nivo AVD 6 cycles or 4 doses of Nivo followed by concomitant AVD with nivolumab, and when followed by 30 grade radiation, when they said the overall survival, when they said 100%, and the progression-free survival almost touching 100%, 98 to 100%. So not bad. So this is also available with us and can be considered based on this study. The more will be required, whether we can use a low dose therapy or a low dose fixed therapy needs to be seen in the context of our country where the finances play a major role. So all this again, and I'm saying whatever this is all 98-100% is good, but don't feel ABVD is bad. You can say ABVD is as good. It remains the standard of care still in majority of the patient. Now, this is the cartoon showing when the compilation of different studies where we have used brentuximab, AVD, and we can say you have this in different centers in stage 1, 2, non-bulky, bulky, favorable, unfavorable, and you can see PFS, the last line, last but one line, 3-year PFS ranging from in the 90s, all the studies, whether it is any study, they were able to show the progression-free survival range was in 93%. And OS also remained above 91% in majority of these studies. So this is a very big leap when they're combining. Third one was this, the pembrolizumab, which I'm personal level, I'm little bit more, when they say PFS OS, that catching, eye catching is the 100%. So sequential 300 milligram every 3 weekly, 3 doses, followed by 4 to 6 cycles of AVD. And when they followed up of 3 years, 100%, everyone is doing well. So this is what we can also do. We are trying in few. And on the concomitant, when they tried with Pembro with AVD with 6 cycles, also the 2-year PFS is 97 and OS being 100%. Very good results. So area of concerns, the only is the financial toxicity, and you can say neuropathy and the neutropenia. These are the few things, and also we have to manage the some CRS with these newer agents. The toxicity will be little different. We should be a little bit aware when especially using the first dose. Now this is the again cartoon which we have the all together nivolumab and pembro. These are different studies by different authors when they published, and you can see PFS and the overall survival ranging in 90 to 100%, more than 90 to 100%, or more than 99%, 98 to 100% in all the 4 studies. Excellent. So this is again can be incorporated. All the 3 drugs is available. A center or multi-center study in Indian context can be taken care if we have to publish our own data. Now, whom to choose? We were thinking which is better So finally, this year another this SWOG study came, the Nivo AVD versus brentuximab AVD. And this the SWOG we said that is in a newly diagnosed stage 3-4 Hodgkin's lymphoma, and it was randomized 1-to-1, and it was fixed dosing. And finally, when they did the analysis, the Nivo AVD arm did little better than the BV-AVD. See, we are in statistical comparison, although it's significant, 94 versus 86, favoring Nivo-AVD arm, but it's, again, 86% is not that bad. It's even better than giving ABVD. So the confusion, so if you have to combine with whether we have to give Nivo-AVD or BV-AVD, okay, this trial definitely it goes in favor of nivolumab. But if we compare with ABVD alone, both are as good. So this was in the frontline setting. Still, we have now an option of plenty which drug to choose initially, whether it will go to the ABVD alone or combining with either nivolumab, brentuximab, or pembrolizumab. In relapsed and refractory settings, so this is the another when it came, the Adcetris was initially presented. This was like all the relapsed refractory patients given in single agent, they had a response by single agent brentuximab, and they finally were going to salvage some of the patients who were being relapsed post-autologous also came into CR. So this is the SGN35. Again, you can say overall response rate with 75% and 35% achieving single agent Adcetris. So this is the follow-up. Probability of is in the range of 40%, PFS in the range of 30%. So then coming to the NCCN guideline, it all came into the relapse second line setting or the refractory, this brentuximab vedotin, and also going to the maintenance last will come the slide next. So in the salvage setting, this came the block. So what we did, the brentuximab also can be combined with nivolumab in the relapsed refractory setting with a chemo-free regimen. No chemotherapy. This was again whether they had done transplant or no transplant. So no transplant, only 2 to 4 cycles. The response rate was in the range of 70-80%. These are all relapsed refractory cases. And those who were transplanted, it went into 90%. So 2 to 4 cycles. Most of the time patient were transplanted, autologous transplant done. So this was in came. If you don't want to give chemotherapy, if the patient is not fit, give brentuximab vedotin with nivolumab. This is another good combination. This is a cartoon which is depicting the response rate of the combination, whether you are using single agent brentuximab or with bendamustine, brentuximab with nivolumab, brentumax ESHAP with chemotherapies, ICE or ESHAP, single agent pembrolizumab or pembro-GVD. So if you can see the last one, pembro-GVD, the last cartoon, it's the overall response rate of 100%, that's which catches the eye in relapsed setting, which you can say. So also the 31 patient, toxicity in the, this was in 36 or 37 patient was the first which was published 3 years back in ASH, which showed 100% of response rates. Now, last part is the post-transplant consolidation. This is the Athira trial, we all know. Just keeping up with the time that those patients who were planned for post-transplant maintenance of, with brentuximab, they had better probability. The median PFS with brentuximab who received this was 42.9 versus placebo was 24. So definitely going in favor of brentuximab maintenance. Only thing is what we recommend and what we really practice. We have been recommending this to all patients of relapse, especially early relapse or the refractory 2-line failure, those who have gone into the remission, the maintenance, but how long, and it can be given in Indian settings, whether low dose, a few cycles or long, has to be taken. With this, I will end and back to the sponsors. Thank you.
Thank you, Dr. Reyes, for keeping time and giving us 5 more minutes to keep up with the rest of the presentation. Any questions from the audience? We can have probably one. Okay. Yeah, please.
Thank you, Dr. Reyes, for a nice presentation. So I think Hodgkin's lymphoma is one lymphoma where escalation and de-escalation has been very popular strategy. So do you think or see any scope for a strategy like BV, AVD for 2 cycles, PET2, CR, remove the costly agent and continue, or Nivo AVD, PET2 negative, and you do the same?
I think so. Should be done. It should be. We can take this again, and it can be taken this type of low dose low fixed dose, those who have a good response, and we can de-escalate in using immunochemotherapy initially and stopping once the patient has achieved complete remission, especially in the favorable group if we have those patients. So at least aiming to achieve 100% OS and PFS, that can be done, it's achievable.
If there are no more questions, thank you so much, Dr. Riaz.
Thank you.
Thank you. So the next talk is Dr. Joseph John. Joseph needs no introduction to this audience, and he is going to talk about first-line therapy for diffuse large B-cell lymphoma, the evolution in first-line treatment. All yours, Joseph. Yeah.
Thank you, Dr. Manju. Nice to see the real lymphoma warriors sitting here at evening of the day. This is a Roche-supported meeting, and some of the mandatory slides I have to show. And my presentation would be on the goals and rationale of the first-line multi-agent therapy, a de-escalation strategy in early disease, or we can improve the outcome in advanced stage, and the role of polatuzumab in untreated DLBCL. In general, when we treat any lymphoma, we need to see that we must achieve a long-term survival or a cure with reduced short-term and long-term toxicity. That's our one-point goal, a hard endpoint, what we want to achieve. So came the multi-agent chemoimmunotherapy context and improve the efficacy and overcoming the resistance. And this is promoted none other than by Paul Ehrlich. Last month was his death anniversary. And from then onwards, this magic bullet, the term came up, and we kind of reached that in 2000 when we had the imatinib. Just for a recollection for the students, the importance to know the Goldie-Goldman hypothesis for giving, the rationale for giving multi-agent chemotherapy in any cancer. Don't attack, it's a multi-pronged attack because you are reducing the chances of resistance if you approach from various sites. Otherwise, the rogue cancer cells are likely to gain a mutation which would give him the preferential proliferative advantage. So the multi-agent chemotherapy, the principle to use is use your best agents upfront. Don't save it for relapse. Use everything is upfront. You heard that in the Hodgkin's also, to bring in brentuximab, vedotin, and nivolumab upfront rather than waiting for a relapse to happen. So withholding a useful drug for a possible future treatment failure might increases the likelihood of such an event. That's the whole rationale on which this Goldie-Goldman proposed it in '83. And it was there, they used it significantly with the mathematical model. So we have two diseases to attack, two situations in non-Hodgkin's DLBCL to approach. One is limited stage disease and advanced, and this is the current IPSS-wise, the outcomes which we have. Now we want to see if we can improve on any one of them. Did a Google search, not a PubMed search or a PubMed. If you put untreated and diffuse, there are 539 citations. If you put first line, so if I have to give the talk, I have to go through all these papers and the findings, which I'm not going to do that. And if you had to do this, that's how it will look like if you were to do a comprehensive review of this entire topic. So giving you an overview over the years, the landscape has changed from CHOP alone, and almost 15 to 20 years we are seeing a new kid on the block who's kind of changing the entire thing across. That is CHOP, rituximab, then rituximab plus CHOP, and then now we are talking about polatuzumab. In the first early stage, we are looking at can we de-escalate the therapy. In the elderly, we came up with the mini-CHOP and said 80 years plus, come with mini-CHOP, less side effects. In the younger age group, if the IPI is low, and the FLYER study came up and said, you do not have to give 6 cycles or 8 cycles, you can manage with 4. So in early stage, limited disease, CHOP 4 is good enough. This is after a PET positivity, and this is how the algorithms come from UpToDate or NCCN for that matter. That's a flyer study. I think we must remember this because that is where the 6 to 8 has come down to 4 in the early stage. So PFS was still at 96, 94, 89, 89 on EFS, and the overall survival, not OD, overall survival 99 and 98. So we have an answer in the early stage to say that you can de-escalate to 4 and get the same advantage, but it is not R-CHOP into 4 alone, but followed by 2 more Rs. Now comes the advanced stage issue, where 3 and 4, I want to intensify, I want to balance the efficacy and reduce the safety. Balancing the efficacy safety has been always a challenge. And of course, the third parameter is a cost. So after R-CHOP, what next? And we said cell of origin, MIC, double expression, triple expression. Last 4 years, all the conferences, almost half a day was spent on the cell of origin and the ABC and the GCs, and the debates went on, and we looked at various options to see how we can get over this doublet, triplet with little advantage at the end of it. And in-depth molecular profiling is coming in now. So now we have up to 2022, from the last 20 years, went through this whole exercise of R-EPOC and R-CHOEP and DA-EPOC and RDA-EPOC, Codoxembac, Bortezomib, anything but everything thrown in, but not much of difference even in PFS, and it was counterbalanced by increased toxicity. So early intensified chemotherapy may exert an anti-lymphoma effect, but it was not giving us the advantages in terms of the safety part of it. So intensified chemotherapy logically was good for high grade. Intensify was a thought process, and this is where the benchmarking we can do for what can R-CHOP provide to us as of today. EFS versus PFS versus OS. There will be some confusion to that understanding. I'll come to that words later. But essentially, this is where we need to benchmark. Anything which can give you better than this at 5 years could be considered superior. That's where I want you to apply your critical thinking, even if we promote or discuss about polatuzumab based upon the NEGM paper. So GOA trial came up with the rituximab, obinutuzumab, already went through that, no improvement in OS, R-CHOEP, R-DA-EPOC, no advantage. So now from there came POLA-R-CHP, and vincristine was omitted, O was oncovin, that was omitted. Both of them have similar side effects of peripheral neuropathy, therefore vincristine is removed from there. So now we have to critically think and say how much advantage does polatuzumab have over R-CHOP. So just to give you some general knowledge on why polatuzumab is called polatuzumab. Pola is a unique identifier. I said tuzu is the tumor, zu is humanized, mab is monoclonal antibody. That is fixed. Infix and suffix is always fixed. Prefix is the one which is a unique identifier. Vedotin is a biological missile, and that is why it is called the payload. The MME, MMAE, the monomethyl auristatin E, which is put in, is the payload. So the antibody will bring it to the cell, deliver it through the linker molecule, deliver it inside the cancer cell, and does the damage. So we have vedotin in terms of brentuximab vedotin and polatuzumab vedotin. So that is how it looks like, the antibody attached to this payload here with the cytotoxic drug, and that's destroying the cancer cells. So this is to show that polatuzumab is attached to CD79B. And that brings it to the B cell, and it is internalized, and then the vedotin is released, and the auristatin will attack the microtubules just like the vincristine, and it is like a Scud missile at the site of the cancer cell. So let's just go through the NEGM paper, critically analyzing it overview. So they did 2 arms were there, 1:1, pola vedotin with RHP with vincristine placebo. This is a dummy trial they had to do, and for R-CHOP they had to give polatuzumab placebo, the look-alike drugs they had to give. The primary endpoint was a PFS by the investigator. They also had an independent committee also looking at it, and the secondaries were EFS and the DFS and the OS. Both the sides were balanced, 400 plus candidates, patients on both sides, and plus your doublet and the triplets were almost the same. In terms of efficacy, we are looking at The hard endpoint of this study was the PFS study, which is the 76 versus 70. Now, as of now, we understand that it is only a 6.5 percentage of 7.5. You can also say the glass is half full. There is a 6.5 percentage advantage at 2 months versus there is only a 6.5 percentage. That's how you look at it. But in terms of if cost is not an issue, I would say why not that 6.5? Same thing if they had to do an additional follow-up study for a few more months, and that also showed an advantage of both separated out. EFS versus DFS. EFS means they used death, progression, relapse, or any events of subsequent therapy of lymphoma or biopsy-confirmed residual disease. On the other hand, the PFS does not include other therapy or residual disease. So one is EFS, that is the event-free survival, which takes into everything. Disease-free survival or progression-free survival is slightly, it will always be better because it does not include relapse, subsequent therapies or residual disease. In terms of disease, that is a disease-free survival, but when they had a blinded centralized review, there was not much difference between this, but there is some advantage now you can garner and say, okay, slightly better. Overall survival had no advantage of polatuzumab here. And in terms of subsequent therapy-wise, Pola was slightly better off. Now the question is to do a subgroup analysis. So it's all based upon one NEJM paper in 2022. Subgroup analysis to look at where else could we have put in. So we do that in all the studies. No harm. It is a post hoc analysis just to see can the high-grade lymphomas or a double hit be better responsive to polatuzumab. So that's where now we have to figure out saying if the cost is high, is there a subgroup of patients whom we can use that? And that is where it comes in terms of lesser side effect and a slightly higher advantage. And if you look down here, the double expressors, not really, this confidence will not to this side, but at least it is showing a trend towards a Pola better than the Archo better. So if it is double hit, no or unknown or yes, triple hit was on the other side it went to, but when it comes to double expressor, this was better on the Pola arm. So obviously there is a lot of molecular heterogeneity in the molecular of DLBCL. Again, that is the same to show why the PFS on the Kaplan-Meier graph, and the elderly efficacy was slightly better off in the Pola. So in other words, we are coming to a group saying that elderly, high-grade Pola may be having a role there. Generalizability, if you look at the geographic region, Asia was about 20% there, and the subgroup analysis showed both PFS and OS benefits in the Asian groups as well. And the summary to say that, of course, polatuzumab gives you a 6.5% advantage in the PFS. OS was not so great, but in the long-term follow-up, we may be able to get a better results there. It has come into the NCCN guidelines as well, and it can be used in the upfront therapy, and it is FDA approved. So we talked only about the Pola, but there are many players coming into the game here with bispecific antibodies, small molecules. But just to understand, we must understand the Zuma trials coming in. If you were to use CART after polatuzumab, there could be a problem, because CART is going to harness the CD79B. And if you have already been exposed to polatuzumab, there may be a problem using CART subsequently. These are limitations of the study. More data has to come, more biomarkers have to come. From evidence to decision making, of course, cost effectiveness will be the answer there. Pola, there were 7-8 studies from Japan and Germany and the US, kind of balancing out, not so great an advantage there, but there is reasonably better. But these are things which is going to come in, and I understand from the sponsors saying that the pricing is still not yet done, and that is what is going to make a decision making, allowing us to make the decision better. Thank you.
Thank you, Joseph. That was really brilliant discussion. Any questions from the audience? We can have one. Okay. I I'll ask you a question. So if you look at your R-CHOP versus CHOP data, whether we talk about GALA trial, whether we talk about MINT trial, in both of them, the OS benefit was demonstrated at the end of 2 years. We are not seeing that in POLA, and our typical answer for most of the times is that we need longer follow-up. Do you agree with this, or you have some other points to highlight?
So the postulations can be conjunctural here with anybody else. Even the authors had mentioned that they're not sure why, even though the PFS was slightly better, why didn't it translate to an OS? And that's a moot question we have for all low-grade lymphomas as well. And short of any better answer, we say it is molecular heterogeneity, which we don't understand. That's all I can also say. I mean, I can also allude to that only. But at least a 10 to 20% difference is, in my mind, is a reasonable difference to say that, it is like in R, when it came in over the CHOP, it gave a 20% advantage. It all depends upon the cost and the acceptability of willingness to pay at the end of it, which will guide that.
Very useful talk. So speaking of DLBCL, the easiest pathological prognostication that we have today is cell of origin, easily doable, IHC, Hans algorithm, ABC and GCB. Double hit is still very difficult. I am sure Tata and all some centers are doing routinely, and they will also find 6 to 8% patients only. Now, if you go on the POLA R-CHOP paper in RCHP paper in the NEJM, activated B cell did clearly better with this combination. So can we conclude that at least in today's practice, if somebody is able to afford, clearly we can use POLA RCHP for ABC subset of DLBCL?
So at the end of it, as you said, that is the best we can place this right now in my mind. High risk, elderly, not elderly, also high risk, like you said, the ABC or a double hit if you have. Consider that there, and on casual discussion with other countries also, it is a similar thought there. There is no policies in many countries there, but they are using that in ABC and the double hits.
Well, thank you, Dr. Joseph, for this excellent talk, and round of applause for this to him. And I'm now very pleased to invite Dr. Pooja Prasad. Dr. Pooja is MD DM Hematology and currently serving as Assistant Professor in Department of Medical Oncology, Adult Hematolymphoid DMG at Homi Bhabha Cancer Hospital nearby, our ex-colleague and a friend. Pooja is going to speak on evolving treatment in relapsed refractory DLBCL. Over to you, Pooja.
Good evening, everyone. I would like to thank the organizers for giving me this opportunity to present on this prestigious platform. I will be presenting the data on evolving treatment landscape in relapsed refractory DLBCL. This session is sponsored by Roche, and few of the slides have been provided by them. So as we know that most DLBCLs are cured by upfront chemoimmunotherapy regimens like R-CHOP. However, around 30 to 40% patients will either relapse or have refractory disease. The standard of care for these patients historically has been salvage chemotherapy followed by autologous stem cell transplant. But this approach has been limited due to the intensity of chemotherapy and the proportion of patients who relapse after auto transplant. So after frontline R-CHOP therapy, around 60 to 65% patients would be cured, and 20 to 25% will have a relapse after achieving CR, and 15% would be refractory. The survival of these refractory patients and also of relapsed refractory patients after multiple lines of therapy and post-transplant occurring within less than a year is dismal, with around 6 to 7 months of median survival. But there is hope, as the treatment landscape has been evolving in relapsed refractory DLBCL with the approval of several new CAR T cells, immunotherapy options, bispecific antibodies, which have been in the pipeline. So coming to CAR T cells, which were initially studied in multiple relapsed DLBCL setting, in the third line setting, the approval for the 3 CAR T-cell antibodies, Axi-cell, Tisa-cell, and Liso-cell, came from the pivotal trials done under the Zuma-1 study, Juliet trial, and the Transcend study. These 3 trials demonstrated an CR rate of around 50% with a median progression-free survival of around 6 months. The grade 3 toxicities were seen in around 11 to 20% patients. With these trials, the 3 CAR T-cell constructs were given FDA approval in 2018. Subsequently, these CAR T therapies were also evaluated in the second-line setting post-initial chemoimmunotherapy. So this is a table which is summarizing the data and the characteristics of the 3 trials. This is not a head-to-head comparison between the 3 CD19 CAR T-cell antibodies. So the Zuma-7 study, which recruited around 360 patients and compared Axi-cell with standard of care, and Belinda trial, which recruited 322 patients and compared the efficacy between Tisa-cell with the standard of care, and Transform study, which had around 200 patients and compared Liso-cell with standard of care. So we can see in the 3 groups, the cohorts had patients in the age group of above 65% in around 30% cases, that is 1/3 of the cohorts, and stage 3-4 disease was seen in around 70 to 80% of the patients. So at a median follow-up of 25 months, Zuma-7 showed Axi-cell having a median event-free survival of 8.3 months in comparison with 2 months in the standard of care arm. And the overall response rate was 83% with median PFS of 14.7 months. The Transform study, which demonstrated a median EFS of 10 months at median follow-up of 6 months in the Tisa-cell arm, had an overall response rate of 86%. The Belinda trial did not achieve the primary endpoint, and so only Axi-cell and Liso-cell were given FDA approval in the second-line setting last year. The other non-CAR T-cell therapies which have come up include immunotherapy options and ADCs like polatuzumab, as has been very nicely explained by Dr. Joseph John, and other immunotherapy options like tafasitamab, selinexor, and bispecific antibodies. So we will be taking these drugs one by one. So there were studies which evaluated the efficacy of polatuzumab monotherapy, and it had found an overall response rate of around 13 to 50% and a progression-free survival of less than 2 months. So it was planned to combine polatuzumab with bendamustine rituximab, and the pivotal study GO29365 evaluated this combination of polatuzumab with bendamustine rituximab and compared it with bendamustine rituximab alone in transplant-ineligible relapsed refractory DLBCL patients. So this had a phase 1B arm, which was a safety run-in study, which recruited 6 patients in both the groups. Then there was a randomization phase in which there were 40 patients in both the subgroups, and a phase 2 extension study, which recruited 106 patients. So the primary endpoint was complete response, which was seen in 40% of the group of the Pola plus BR arm and 17.5% in the BR arm. The Pola plus BR cohort also showed more than doubled median duration of response of 10.3 months in comparison with 4.1 months of median duration of response in the BR arm. The median progression-free survival was 7.6 months in the combination arm, which was around 3 times greater than that of seen in the BR group. And the evaluation of BR in transplant-ineligible relapsed refractory DLBCL has been done previously as well, and the PFS was found to be 3 months. The median overall survival in the Pola plus BR arm was 12.4 months, which was around 2 times more than that in the BR arm. In the efficacy outcomes, CR rates of around 40% were seen in both the cohorts, and the median PFS was around 9 months. And this improved progression-free survival as well as overall survival with this POLA plus BR persisted and was also seen in the extended follow-up study which was published, which had an extended follow-up of around 5 years. So POLA BR had a 9.2 months progression-free survival and a median overall survival of 12.4 months. And this OS benefit persisted at longer follow-up as well. The 2-year OS is 38%. The combination of polatuzumab plus bendamustine rituximab have some adverse events, mainly cytopenias and peripheral neuropathy and infections. But most of the toxicities that were found in this cohort were manageable as well as reversible. Peripheral neuropathy was only seen as grade 1. Grade 3 and 4 toxicities were rare in the POLA plus BR arm. There are other ongoing studies which are evaluating the role of polatuzumab in combination with other known chemotherapy combinations like R-GMOX in relapsed refractory DLBCL. So this study is still ongoing, but the initial safety run-in results have come, and in that they have till now recruited 15 patients, and they found grade 3 and grade 4 adverse events in 5 patients, and there were no case of any grade 3 peripheral neuropathy till now. The further results are still under evaluation. There's also an ongoing study of bridge to transplant study, which is investigating the combination of polatuzumab with R-ICE in relapsed refractory DLBCL setting. In this, their primary endpoint is a 2-year EFS, and efficacy and safety will also be evaluated. This is still ongoing. So after polatuzumab, then we come on to tafasatimab. This is also an anti-CD19 antibody, and this has been like an immunotherapy, and it is being studied in combination with lenalidomide in relapsed refractory DLBCL patients under the L-MIND study. So in this phase 2 multi-center study, they have taken the relapsed refractory DLBCL patients, not the primary refractory ones, which is one of the drawbacks of this study, but patients who have received multiple 1 to 3 prior regimens, and they are evaluating the dose and the overall response rate of the combination of tafasitamab with lenalidomide, and secondary endpoints are PFS and overall survival. So till the 2020 data cutoff, 46% overall response rates have been seen with the median PFS of 11.6 months. The main toxicities that were noted are cytopenias, febrile neutropenia, and hypokalemia in around 6% patients. The bispecific antibodies, CD20, CD3 bispecific antibodies which have demonstrated activity in relapsed refractory DLBCL include mosunetuzumab, odronextamab, eporicatamab, and glofitamab. These are all tongue twister names. But in the studies that have been done, these bispecific antibodies have been used in patients who are relapsing post-CAR T-cell therapy, and an overall response rate of around 30 to 35% has been noted. And with this, glofitamab has got FDA approval in 2022 for third-line setting as well. So when we are optimizing DLBCL therapy in the second-line setting, the main important thing to be noted is the time to relapse from frontline therapy. So if the timing of relapse from frontline is less than 1 year, and patients are eligible for CAR T-cell therapy, which is seen usually in around 70% patients, they should get the benefit of CAR T-cell, either axi-cell or liso-cell. and of that, around 30 to 40% will get this therapy, and there is a projected cure of around 20% in this group. The patients who are relapsing around 1 year after the frontline therapy, and they are eligible for transplant, which is seen in around 50% of the cohort, they undergo second-line salvage chemotherapy with platinum-based regimens, followed by autologous stem cell transplant, and of that, around 40 to 50% patients will get cured. So there is a projected cure of 5% of patients. And the patients who are not eligible for CAR T-cell as well as transplant, they should move on to, they move on to second-line or third-line therapeutic options, which have been discussed, like polatuzumab, selinexor, tafasitamab, loncastuximab, and CAR T-cell therapies. And if nothing works, then we have to move on to radiotherapy or best supportive care. Now, to conclude, CAR T-cell therapies are promising options for difficult to treat early relapsers. However, the cost is prohibitive right now. The combination of polatuzumab plus bendamustine rituximab and tafasitamab plus lenalidomide has significantly improved CR rates and survival outcomes in patients with relapsed refractory DLBCL with an acceptable safety profile. Bispecific antibodies are showing promise in patients who are relapsing post-CAR T-cell, but there is still limited data on what is the best sequencing approach. And there are several unmet questions, unanswered questions that exist, whether the role of auto-transplant will diminish in the future with the advent of these therapies. Can we expect these therapies to move to the front line for high-grade lymphomas, and how to manage relapses occurring after these therapies? So these are some questions. Hopefully the panel discussion, which is going to be held subsequently, will throw some light on them. Thank you.
Thanks, Pooja. That was really nice summary of what all is available and what we can look forward in future. Any questions from the audience? And I must give a pat on our backs. We made up for the time which was not available. So thank you, everyone. Yeah, please.
Thank you.
Yeah, I will come up with the same thing which I said in the myeloma session, okay? You have just verbatim talked about what is there in US guidelines, this review from ASH. How much do they apply in our setup, tell me? You are talking of axi-cell, Tisa-cell as the preferred therapy in 70% of patients. It's not available.
Yes, sir.
So when you are giving a talk in an Indian setting, talk in the context of the country, what we have and what we could do in this setting, number one. Number two, you did not mention at all. See, when you are reviewing the data and you are looking at the current literature, the last 2 years has been completely hijacked by CAR T cells and the CAR T groups. So what is this guideline based on? Have you looked at the original data based on which these recommendations are made? I mean, actually, in my talk tomorrow, I had actually thought about including this part, but then there was no time and I have taken it out. But this is an important observation that 2 publications came out in the same issue of NEJM. For those who do not know, please look up that particular issue of NEJM. I don't remember that, but 2021, I suppose it was, Tisa-cell and axi-cell versus standard of care. Both the studies had around 170 odd patients in each group. So Tisa-cell and versus SOC had no superiority of Tisa-cell over SOC, okay? Standard of care being R with D-happy, sharp eyes, blah, 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 etc., followed by an autograft, if possible. In axi-cell, they showed a superiority in progression-free survival of around 10% without any improvement in overall survival. So based on this singular data, the whole recommendation was made. Now, when I looked inside the paper, this is what is there in the abstract. When you look inside the paper in both the studies, autograft was available to only 30 out of 170 patients. And based on this skewed observation, this is what happens when we do not get into the study. Based on this skewed observation where only 30 patients received an autograft, and even then there was no subgroup analysis saying that whether who received autograft did better than those who did not receive autograft in the SOC group, a recommendation was made in the European forum, in the American forum, that CAR-T should be the second-line therapy before autograft. So there was another publication 2 months back in Transplantation and Cellular Therapy, it was previously BBMT, from David Porter's group on real-world experience, single-center real-world experience, and again, please read that paper. It was on around 80-odd patients, non-randomized data, which showed that in real-world experience, even within 1 year relapse, autograft did 20% better than CAR-T. So before we come to any conclusions based on guidelines which are heavily funded, sponsored by big pharmas who are promoting the individual drugs or procedures or therapies, do in-depth reading before making these recommendations. Thank you.
Thank you for that
Yes, sir.
comment, and I must say that Pooja did a really nice job of summarizing what is available. It's important for us to go back and read the articles and understand what is lacking. The critical appraisal of each and every article is important, rather than just accepting the therapies. And I would definitely encourage all of you to read these two NEJM articles, what he was referring to, and see why those patients were not taken up for autologous stem cell transplant. So definitely read that. There is a very clear description of what is the difference between these three trials and why 2 of them were positive and 1 was negative. So it's important to read it and understand it. And always look at, when we talk about real-world data, that what are the differences in a real-world data versus a randomized control trial. So it's very important to understand these differences before you make your own conclusion, and we try and say that anything which comes out in any NEJM is not good. So thank you so much, Pooja. That was really a nice presentation.
So I think with this, we are at the last talk or panel discussion of this day. And thanks everyone who stayed back for this at this hour. And for this, it's my pleasure to invite distinguished speaker, Dr. Hari Menon, who is my senior also, currently professor and head at St. John's Medical College Hospital in Bangalore. And the panelists are Dr. Charanpreet Singh, my colleague. Please, Charanpreet, can you come up? Please put the chair. Dr. Sandeep Kukkar and Dr. Sachin Gupta, who are senior medical oncologists in Tri-City, Chandigarh area. I think all 3 panelists can come up, and you can put the chair for the panelists. मैम हम इधर आ जाते हैं या
Thank you, Gaurav. Thank you, Manju. While my esteemed panelists take their seat, I'll just say that this time in a panel discussion, I've tried to make it as simple, and I've tried to look at only the frontline setting of patients treated with diffuse large B-cell lymphoma and how to optimize the treatment outcomes. And so I will not run into Suparno just now as far as having to deal with questions about transplant in the frontline setting. Yeah. So he's not listening. Yeah.
Hari, before you begin, I think it would be good that if Pooja and Joseph are also here,
yes,
you will
yes,
have
please.
little extended panel. Yeah.
Yes. Yes.
Yeah, and Dr. Reyes. Yeah.
Yeah.
So though it's DLBCL, but
yeah.
there is no harm.
Yeah. So just to initiate the discussion over here, so I just would go to say that diffuse large B-cell lymphoma, as we typically see, are something that you cannot distinguish on a morphology. They are large cells with loss of follicular architecture. That's what you see. But we also know they're highly chemosensitive, and in about 50% of patients they are curable. But we also know that the outcomes are extremely variable, and there is a lot of heterogeneity in this disease, and this heterogeneity lies at the morphological level sometimes, and at the genetic and the immunophenotypic, and at the clinical level too. We also understand that about 50 to 60% are already cured with previous chemotherapies, and currently it has not really changed from the rituximab plus CHOP regimen. About 20 to 30% definitely relapse whatever we do, but 5% go into a partial response, and 15 to 25% are refractory to any kind of therapy. So in this first subgroup, which is in the blue, this unlikely, whatever we do is unlikely to improve more on that actually in the subset. And it's probably in the subset that is above that we need to identify subgroups beforehand to improve the outcomes. And with that, we see would you agree with, I'll start with the panelists, that R-CHOP is a continuous standard of care, but does not cure many diffuse large B-cell lymphomas. And I can start with your thought, and Sachin can take the first question. Why do you think this is the case?
R-CHOP has been
You need to switch on your mic.
yeah. So R-CHOP has been this standard of care for many, many decades now. And so many strategies have been incorporated at various point of times. So using more, adding more cytotoxic agents, adding lenalidomide, ibrutinib, and so stratification according to double expressor and this double hit, triple hit, or DAR epoch, and even more toxic regimens. But nothing has stood the test of times, and R-CHOP has been the standard.
Yeah.
And limitations are the clinical criteria. The patients are elderly, patients are not able to handle too much of toxicity of additional drugs. Then so when we, so there are the ibrutinib and lenalidomide also did not, they did give some benefit in some patients, but again it didn't stood the test of times and could not become the standard of care in this.
Okay.
So as you have pointed out in your slide, this 50 to 60% are doing good enough, but the 25-30% who are not doing good enough, we still don't know how to manage them. So now with bispecific antibodies, with let's say CAR-T and using polatuzumab, so some of these strategies are showing up, may be beneficial, and some of these patients may be better manageable. But I don't think we still have an answer how to best manage these 25% patients.
So I can ask Chamanpreet, where do you think is that you would like to have a change as far as R-CHOP is concerned in the treatment of diffuse large B-cell lymphoma? And where do you think you would not want to make a change at all when a patient is confronted in front of you? Yes.
So I think, as was highlighted by Professor Joseph John, in the good risk, low IPI, limited stage DLBCLs, we are doing pretty well with R-CHOP, and we're actually looking at de-escalating therapy as opposed to adding on drugs. So that's where we probably don't need to add additional drugs. However, if we are to look at certain subgroups of patients, such as those with double hit or double even expressors at baseline or very high IPIs, as you've mentioned, those are patients who we know will not generally do too well with just plain R-CHOP. So those are patients who would want maybe something additional. One more subgroup of patients would be those who have a particularly high CNS IPI, and those are at risk of CNS relapse and CNS progression. That is a major unmet need in patients with aggressive diffuse large B-cell lymphoma.
All right.
So I think IPI has been one of the criteria that has stood the test of time, and in the clinical practice, I think it is the most used criteria, and it can be used for selection of patients, those who are at high risk of relapse,
right,
probably with a higher IPI. And as said, double hit lymphomas, they are the kind of patients where you need something more than R-CHOP. So.
Okay, so do you always look for a double hit lymphoma in all your patients who come? I mean,
you can maybe say that it's aggressive. Yeah.
So if that is the case, if the double hit, and if you find that on the higher side it's having a low IPI, and you still find it's a double hit lymphoma, are you going to change your method of treatment for such patients?
As of right now, even if I know it's a double hit, it would be tough to offer something other than R-CHOP, because all we have is maybe retrospective data to suggest that maybe these patients do better with DA-APOC-R. Other than that, prospective data for even more aggressive chemotherapies in patients with even double hit who are proven is, I think, lacking as of right now.
Yeah, so that's what some of the more recent data is coming in, but you may not want to use a dose-adjusted EPOC for all double-hit lymphomas, even if they are in an early stage disease, and they just do as well. Agree with that, Sachin? And is that
even if we find out double hit and a high-risk patient, it's difficult to still manage these patients.
Yeah.
And even DA-APOC is not very easy to handle, and the toxicity, and most of these patients are elderly.
Yeah. No, my question
all patients
is,
are not candidate for this.
My question is, if it's an early stage and you, by whatever, you do find that it's a double hit lymphoma over here, would you still stick with R-CHOP and do some modifications in that, or would you still want to go with the dosage?
For a younger patient, I would consider the patient it belongs to a, if you can handle the cost and admissions and the longer stay in hospital, so all those factors also come into play. Otherwise, R-CHOP is, I think most of the times it's R-CHOP.
Yeah, okay.
So I would disagree here. So I think the data which was there showed that in patients who had limited stage double hit lymphomas, R-CHOP was equivalent to DA-APOC-R.
Yes.
But in advanced stage patients or with high IPI, that is where DA-APOC-R scored over R-CHOP. So maybe in limited stage, I would not.
What about radiotherapy? If it's a double hit lymphoma early stage, would you exercise the option of radiotherapy to that?
Just radiotherapy?
Yeah, and also what about CNS prophylaxis over there?
CNS prophylaxis, I think, is a question which nobody has an answer to.
In the scenario of a double hit, I'm just going off the cuff actually, I'm not going according to my slides, but just,
So CNS prophylaxis, even to those who we know have a high-risk CNS IPI or other high-risk features which would predispose them, we know that the high-dose methotrexate strategy or other things don't really work too well. So even if we do decide to give them CNS prophylaxis, what is the correct way to give it, or what is the age in which we can give is questionable. As far as radiotherapy alone in a limited stage, I would not probably go for it. After 3 or 4 cycles, maybe, but yeah.
Yeah, please. Yes, Sandeep.
So if radiation has to be considered after 3 to 4 cycles of R-CHOP, we do.
But you would not abbreviate the number of courses over here, will you, if it is a double hit?
I think
if it's an early stage double hit, would you abbreviate the number of courses?
Probably
we don't know.
Yeah.
Yeah, okay. So I think that was just a good start, and let's look at the objective of this basic panel is, can we prognosticate DLBL better? That's the thing. And can we have better cure rates in these patients? And is it possible to improve the survival through yet defined strategies? And what about novel therapies, which again, this is a symposium which is by Roche, and we don't have too many things over there in terms of improvement, and polatuzumab is one of them. So can we prognosticate DLBL better? What do you do in your clinic? And yeah, I can start with Sandeep. Yeah.
So I think, sir, we use the IPI score, and as far as the simplification with Hans algorithm is concerned, we go for GCB versus a non-GCB testing. And thirdly, FISH for IHC for MYC as well as BCL2 and BCL6. That's the only thing that we do in our day-to-day practice.
And Dr. Sachin, I mean, what about the cell? How much emphasis do you place in your practice for identifying cell of origin?
Besides, as far as testing is concerned, so these are things available to us easily, and so we go for IHC and FISH testing to prove double expressor and double hit, triple hit, and so this is where we come to GCB versus non-GCB.
Right. Yeah.
So by and large it ends here plus the clinical IPI scoring.
Despite its limitations and probably this thing we still rely upon, but we do understand that with the gene expression profiling, we have these two distinct different outcomes to one single type of therapy. Dr. Chamran, do you at PGI, do we have always the cell of origin other than just doing it
No, we
by
don't
hands
have
algorithm? Yes,
GPs
okay.
available on.
Okay, I mean, it's time and again proven that prognostic significance of diffuse large B-cell lymphoma, cell of origin, we understand the outcomes are a little different, with the ABC subtypes doing a little worse off than the GCP, and we have better outcomes with GCP subtype, provided the GCP does not have some of those double hit components, etc., that is there. And the cell of origin, of course, we do understand that it is indicative of a distinct biology, and you have the dark zone which is there, and there are a multitude of mutations that are present, especially the BCL2 translocations, the MISC translocation, the EZH2, and the BCL6, BSE1 mutations, and the PTEN deletions which are there. And on the ABC side, which is on the light zone where we call it, there is usually a nuclear kappa factor pathway, and you have CARD11 mutations, and the BCL2 amplification, the PRDM1 mutations. And of course, we have the primary, which we'll not discuss over here, the primary mediastinal B-cell lymphomas. But in addition, there are certain other mutations. Do we really need to look into those? Yeah.
So I think recently they came out with the molecular subtyping of DLBCL, in which they divided into 4 or 5 different types of molecular DLBCL depending on the type of mutations that they have, and they found that certain subtypes did have a better prognosis and sometimes did not. Whether it's truly doable in a clinical practice in our setting, I think is questionable. But yes, the data is definitely there, and that would lead to possibly better personalized therapy in the future if we are able to get it in clinical practice on day-to-day basis.
So the only thing that we find which is having favorable is the EZH2 mutation, and the rest of all of them have it. So yes,
So
Dr. Sandeep.
I think in our clinical practice we are not testing for any mutations, but as Dr. Charanpreet said, there was a paper which classified DLBCL into 7 different molecular types,
Right.
and they gave it the study design was R-CHOP versus R-CHOP-X, the drug according to what the molecular classification is. And it was clearly stated that these are the groups which actually do better, where you target a particular pathway and give the treatment according to that. But that's basically, you can say, evolutionary form of treatment that might be there, say after 5 years, 10 years down the line. But as far as of now, I think it's only R-CHOP that we are giving.
That's right. Dr. Sachin, you have this thing on?
So maybe, once we have more information how to manage these mutations, then addition of those drugs may eventually help.
Yeah.
So that's the way, things are evolving in every field.
So you go, yes, so in the next slide, we just go into the next level of things where you have combination of the EZH2 with other mutations, and that also has an implication. The crosstalk between the mutations actually has, and that's what is reflected in these slides, with especially the ones, as I said, the one with the EZH2, the EZB with co-mutation with B, has got a better outcome as against some of the other, especially the Notch one has got one of the worst outcomes in these patients, and we know that they're likely to do well. Again, coming back to, we have already discussed this, can the understanding of cell of origin, I mean, I just have one common, one of you can take the call. Does cell of origin, is it that important, or are we wasting our time trying to do that? In a clinical scenario, in a clinical setting, pure clinical setting?
So I would say as of today, probably not. But maybe as data is evolving, we would also evolve in the next couple of years.
So if you were to know that it is based on the Hans algorithm, it's an ABC or a GCP subtype,
Yes.
would you make some modifications on that? And is
So,
there something on that?
Up till,
I mean, I know
think,
Sachin just spoke to about it, but yeah.
So this is where we land up to. After investigating, so we differentiate between GCV and non-GCV. So this is where the final diagnosis arrives, and if the patient is an advanced stage, high IPI, so we, at that point of time, we think what different do we do beyond R-CHOP. So these are the strategies like this slide which is being shown, addition of lenalidomide, addition of ibrutinib, or DAR-EPOC. So these are, 2-3 things which I have tried in practice. But there are limitations even in these, addition of these drugs. So like when we add lenalidomide, there are more cytopenias. It's difficult to handle. We end up reducing dosages or stopping lenalidomide in between. And so it is difficult to practice even this regime. And DA-RA, definitely we have, seen few patients who have, handled it, and we have been successful in using that. But beyond this, practically speaking, we are not able to do beyond R-CHOP.
Okay. Yeah, so there's two slides which are in fact published at the same time actually, but a little bit of a differential with the study from the Mayo Clinic showing a distinct improvement with lenalidomide maintenance over here, but not so much with the robust study, which is a phase 2 randomized study, lenalidomide R-CHOP versus placebo plus R-CHOP. And you had alluded to the use of ibrutinib, and this was a study which looked at the ABC subtype of patients, and not too much outcomes and worse outcomes for sometimes patients above the age of 60. And basically the conclusion of that study that it did not meet the primary endpoint of intention to treat or of the ABC population, and was associated with increased toxicity leading to compromised R-CHOP administration, which is the primary treatment that you need to give. Yeah. So, and similarly, the use of bortezomib in these also has been largely a failure. And very many other drugs, would you agree that, unlike in follicular lymphomas, where there have been the newer antibodies that have shown some benefits, it has not really translated into benefit in patients with this thing,
Regarding the Remodel B trial, I think there was an updated analysis which was presented at ASH last year, and then it's just recently been published, which showed that patients who had a ABC subtype did actually do much better in terms of long-term PFS and OS. Obviously, those cells of origins are on the basis of GEP, so whether they are translatable to our clinical practice where we are majorly relying on IHC remains to be seen, but that is one area which obviously will be explored in the future as well.
Yeah.
Exactly. I think some of the trials you have a subset analysis like as from this trial, and other was from the ibrutinib trial, where I think in less than 60 years of population with an ABC type, you had a event-free survival benefit. So some of the extrapolation has been done, but again, the studies have been designed on the basis of GEP profiling, and that we are not doing. So I don't know how much translatable it would be.
Yeah. Okay. Okay. But there were some signals as far as the maintenance lenalidomide in some of the elderly patients, and that's was seen in the REMARK study. Where, but still, any reason why it's not put into practice actually? Because was it because it did not show an overall survival benefit?
I have been using this maintenance lenalidomide in few patients, and I'm happy to use it.
Yeah.
But the dose is something like, let's say, 10-15 milligram of lenalidomide maintenance.
Okay.
And so, of course, we can't randomize like that, but patients have been doing well with this approach.
The next part is that we've discussed this in the initial part of our discussion, so I will just skip through. We have already discussed about abbreviating therapy in early stage, low IPI score, where there is enough data to show that we can get away with the FLIER study showed equivalent results where we can get away with just 4 cycles plus 2 cycles of rituximab. So have you adopted this strategy in your clinical practice routinely?
Yes.
Okay, that's a very short, very quick answer.
No.
Yes, yeah, yes.
So far, no.
No, so you still go ahead with 6 cycles, is it? Even in the low risk, early stage diffuse large B-cell lymphomas.
So the patient population is actually very small. Those who have an age-assisted IPI of 0 and then limited stage disease, that's a very rare patient. You may be seeing one patient in a month. But in those patients, I think there is enough data, not only from the FLIER study, but also the LISA study. Right. There's another JCO paper which used the antibody radioactive compound conjugate if you had a PET positive, and they showed that you didn't even need to add the 2 rituximabs after that. So there's enough evidence, I think, to say that you can safely do it in that rare patient who fulfills all those criteria. But yeah, even if you have even one of those bulky diseases or anything else, they don't fulfill the criteria, and then I'd find it difficult to abbreviate therapy then.
Okay. Okay. So far, no. No. So you still go ahead with 6 cycles, is it? Even in the low risk, early stage diffuse large B-cell lymphomas.
I think
So, any reason why we have still embarking on intensifying therapy sometimes in patients? Yeah, where would you use that in some situations in diffuse large B-cell lymphomas? Because right from 1992, when the CALGB study looked at intensifying therapy, it actually did not show any benefit except for the primary mediastinal B-cell lymphomas, where the MACOB-B regimen showed a benefit. So, is there any situations where you would intensify therapy? Is my question. Other than, of course, we have already discussed the double-hit lymphomas.
So young patient with high IPI, bulky disease, they're MYC mutated or BCL2 mutated, then probably I would like to escalate the therapy with ibrutinib, maybe addition of ibrutinib with R-CHOP.
Provided it's an ABC type.
Provided it is an ABC type, young patient fit enough to tolerate the therapy.
Okay. Dr. Sachin, what's that?
Yeah, these are the patients. On the right side, high IPI and ABC type. So this is where we need to escalate, and this is a subgroup which is not getting benefit and is the high risk group.
Right. Okay. So yes, in some situation where we are sort of inclined towards using intensified therapy, thinking that it might do better, but the data from the CALGB study has really not yielded that kind of a result. But perhaps it is still useful to look at some of those patients with very high IPI and advanced stage disease where we might want to use. So we come back to the come now to the discussion on adding the new drug, which is according to the UK group, probably the last 20 years is the first time that addition of another medication or to the standard R-CHOP has made a dent on the R-CHOP regimen. So your views on where would you want to use this regimen of adding polatuzumab over here in combination on the backbone of an R-CHOP regimen? Let's start with Dr. Sachin. Yeah.
So I think, the high risk group we are just discussing about. So these are the patients, so double expressor and even elderly patients. So these are the patients who would require this. And so although we should have a little longer follow-up and long-term data is still required, because they've shown only PFS benefit as yet. So we do need to look at the OS thing here. If that happens, that would be wonderful. But these are the subgroup where we can add. So if cost is not an issue at all, then this can be considered.
So I'll just ask Manju over here what do you think will be a good time frame for us to say that there's going to be a benefit? Here, this is data of 28 months or so, a median follow-up of 28 months.
The closest exit door may be behind you. So what I feel that, I don't think even the longer follow-up is going to show an OS benefit. More so because, more and more, if you look at the same setup of patients, they are going to have access to CAR T-cell therapy, the bispecific antibodies in both arms. So very unlikely that if we haven't seen an OS benefit till now, it's unlikely that we are going to see it. If you look at the data, the high-risk DLBL, but if you look at the stratification there between IPS 2 and then 3 to 5, the benefit was largely limited to the IPS 2, not so much in 3 to 5. So and again, those who had bulky disease did not do well.
Yes.
So that leaves a very small proportion.
But that's intrinsic to any
I'm just saying that,
monoclonal antibody,
those are the ones which you worry about because they are the ones who are going to do poorly. So if you talk about 3 to 5 is what you're worried about the bulky disease. So you're limited to a very small proportion of entire DLBL in that advanced stage where you can use based on the data. So that's where the limitation.
But the 2/3 of the patients were very high IPI in this study.
No, if you look at, they had stratified the study based on IPS 2 versus 3 to 5. The benefit was largely limited to the 2 IPS 2, not so much for 3 to 5.
Okay.
So you ultimately end up patients who have no bulky disease, their IPS should not be 3 to 5, and that's where you're going to use the POLA.
Yeah.
So very small subset.
So Joseph had made a very this thing. Any comments on that, Joseph? I'm waking you up, yeah? Okay. Yeah, okay. So again, this was all discussed in Joseph's slides quite elegantly. Problem is again overall survey. That is a hard endpoint that we have to look at. But with the availability of so many, as Manju said, availability of so many medications that are, or salvage therapies that are at our hand, you're unlikely to see an overall survival benefit. But this is just an additional modality that we can exercise in patients with high-risk disease or probably high IPI score. And this is the forest plot, which Joseph had mentioned over here, wherein there is a benefit across across all age groups and across all IPIs, and because the had probably a little bit higher IPI scores, 2/3 of the patients, that's what they say, and almost a 6% benefit over here, 6% benefit over here. And to me, the important thing is there was the pushing up of the curve of the double expressor lymphoma. Do you think that that's a very significant kind of a thing? Yes, I'll start with John.
So, like analyzing subgroups of trials which are not powered to answer that question is always fraught with problems. So before we can say that there is possibly a signal, but to say that it defines our therapy would be difficult.
Okay. Any other views, Dr. Sandeep?
So I think in a population which is actually difficult to treat, and you have very limited options available with addition along with R-CHOP, one can consider the data and choose your molecule accordingly, because these are a very difficult population to treat and you don't have many agents to add on with R-CHOP, particularly in a population which is at high risk of relapse.
Yeah, and some, Dr. Sachin, I mean, to me, this was probably also encouraging, even though it's a subgroup analysis about elderly, because it's always a challenge to treat the elderly population, and intrinsically you say that elderly populations do not have as good as an outcome as across all the risk groups. So your views on this and the study?
So here again, the hazard ratio does make sense.
Yes.
Especially in this subgroup. So I think this should be considered, should not be ignored. So as Sandeep also said, so where there is nothing better, at least you have something significantly better. So it's an option to be considered to add.
So so I thought if I had the time, I might just discuss the CNS prophylaxis, but I think we are just on time over here. So
what I just wanted to make a point regarding the elderly subgroup. So the drug payload is the same as brentuximab, and we know that in the elderly population in Echelon-1, there was a lot of neuropathy, especially grade 3, 4 in patients who were in the BV arm, and a lot of them had drug discontinuations and dose reductions. So just a PFS benefit in this elderly subgroup may not be enough. We need to also look at their quality of life, and if they're ending up having grade 3, grade 4 neuropathy in a certain amount, then possibly it's not a good trade-off.
And also the incidence of neutropenia, etc., was higher in these patients, and that may not be taken well by the elderly population. But having said that, there is a benefit.
Difference in quality of life in the
paper, no.
But maybe the
elderly group is what we're looking at.
So I think we are on time, and I think we'll conclude, and I think everybody is ready to go. So, and I just these are my conclusions here. Prognosis and treatment of patients with diffuse large depends on vast clinical and molecular heterogeneity, and it's fundamental to assess the molecular profile in an academic setting, etc. It's not mandatory for us to decide the treatment, because still R-CHOP is probably one of the better lines of therapy. But from an academic perspective, for the future treatments, for example, or to prognosticate a patient, it may be useful for us to. And the futility of chemotherapy approaches in patients diffuse who are refractory to first-line therapy, and understanding the biology is critical. So I've been asked to snooze off. So, and identifying better targets to perturb specific pathways, especially in the ACB and the ADC and the GCB, will be hopefully better. And with that, I thank my panelists for their active participation, and I just had this as an informal discussion, and I hope it was worth its while. Yes, thank you.
Thank you.
Thank you, Hari, for remaining awake and keeping us awake. Thank you so much. Thank you, everyone, for being in the audience. Thank you.
Thank you, moderator and panelists. We are having 3 important announcements. And first one, we are happy to announce that some of the selected abstract presenter will be gifted a free copy of PGI textbook. Kindly check your eligibility at registration desk tomorrow. And our second announcement is regarding the change of timing. Please note that the oral presentation session will start at 2:35 instead of 3:40 p.m. The National Hematology Quiz Journal rounds will take place at 3:40 p.m. after the oral presentation. And our third announcement is regarding the undesirable weather. We are changing the dinner location to the PGI lawn, requesting you and your family to grace the occasion here. Sorry for the inconvenience. With this, I conclude the section. We are looking forward to see you again tomorrow morning.